All right. Good morning, everyone. I'm going to get us started here, and I'll begin with welcoming our guests to Rhode Island. Many of them have not been here much in the past, and glad it's a beautiful day we have here. See if I can advance these slides. These are my disclosures. So precision oncology has been here in Rhode Island, and a bunch of work over a number of years has been maturing. And this year in 2026, there are a couple of significant events. Today's event is the inaugural National Caris Precision Oncology Alliance member meeting at Brown University, which is a mouthful. Later this year, we will bring the International Wind Symposium to Rhode Island in early October. So this is today, and there's an outstanding program ahead of us. And I just wanted to start by acknowledging two invited speakers who will be joining us on a panel a little bit later this morning. Donna Rivera, the president of Clinical Evidence Modernization, and Larry Kessler at the University of Washington. So I'd like to thank colleagues from both Caris and Brown for working tirelessly over, I think, at least 6 months to put this program together. And I'll begin by thanking David Spetzler and James Hambrick, who are speaking this morning about advances in precision medicine and how collaboration with the Caris POA empowers your research. And then this was truly a team effort here at Brown with a number of timely and interesting sessions, co-chaired, and I'll mention their names and sessions to look forward to today. Hina Khan and Sana Raouf in a session on cancer screening, Jeremy Warner and Etche Uzan on unlocking clinical and operational value from existing data sets, Liang Cheng, Galina Lagos, and Matt Hatfield in a session on therapeutic biomarkers, Stephanie Graff, Nicole James, and Kara Matthews on a session on breast and pelvic malignancies, Rob Sobel, Sendar Imani, Patty Dubaleka, Nioli, Ribizi, Akhtar in a session on cancer progression and therapeutic resistance. I would like to give a shout out to Steve Ressler, Ari Vanderwald, Milan Radovich, Yoko Cothran, and Sasha for working to pull this together. So why now? Why today? So Brown University has been a member of the Caris Precision Oncology Alliance since 2019. There's a lot going on here. And last year, I realized it was starting to get difficult to know everything that was going on our own campus. And so the idea popped up, maybe we should have an event. And you know, while there is an annual pre-ASCO events that brings together the Precision Oncology Alliance nationally, there really haven't been regional events. And so it made sense to think about doing something like this. And why not do the first one here at Brown University? And so this inaugural event is a regional meeting that we hope will repeat and complement the annual pre-ASCO event. I will say that Brown has been a leader in the Caris Precision Oncology Alliance. I have served as a member of the executive committee and have chaired the phase 1 group that later became the translational group up until about a couple of years ago. Stephanie Graff has chaired the breast cancer group and has served in the Healthcare Disparities Council. And Evgeny Yakirovich has been a member of the pathology group. In addition to the pre-ASCO event, Caris also has a presence at ASCO disease meetings. So this was in January in San Francisco. Ari Vanderwald and George Sledge and Howard made it to this meeting as well. So I started to collaborate with Caris almost 15 years ago and was interested in colon cancer and metastases at different sites in the body. And 12 years ago at the 50th ASCO meeting in 2014, presented results from a collaboration with Caris while I was still at Penn State University. And this involved the analysis of nearly 7,000 tumors, colorectal cancers, looking for potentially targetable treatment options. This work continued when I moved to Fox Chase Cancer Center and eventually was published about a little over 10 years ago. And the work actually gave us some insights. I think we're still learning about these things, you know, what drives tumors to specific metastatic sites. And some of what came out of this highlighted roles for different genes for which we do have therapeutics, such as HER2, TOPO1, COX2 in bone, MET, MGMT, TOPO2, and RAS. Each had some measurable effect on targeting to specific organs. I will say, you probably can't see the author list, but it's really gratifying to see trainees who were involved with this work long ago who are now, you know, leaders in the field. So there's been, you know, a lot of interest in hyperprogression in cancer. And I became interested in it because I started noticing a literature on MDM2. And this is work of Dr. Razel Kurzrock, who recognized hyperprogression after immune checkpoint blockade. So most patients, you know, who take immune checkpoint therapy don't encounter this, but probably 8 to 10% have this phenomenon of hyperprogression where their tumor actually appears to grow faster after they're treated. And she has been able to associate EGFR and MDM2. And so I became interested in this and launched a collaboration through the Caris POA looking at MDM2 and MDM4 amplification across tumor types with relationships to outcomes after immune checkpoint blockade. And, you know, presented this at ASCO in 2022. We're still working on the paper, but we're making progress. You know, the original study had a hint that maybe MDM4 amplification might be a little more potent, you know, with 4 copies being potent relative to MDM2, where you needed 6 to 8 copies. But as more data accumulated and has been maturing, that doesn't seem to be the case. So the two gene targets seem similarly potent in their relationship to poor outcomes. And I should say that over the years, the idea that these drivers block T cells in response to immune checkpoint blockade comes up in different conversations about cancer vaccines and cancer therapeutics as we work to personalize cancer therapy. So a number of years ago, and one of the things I really love about Brown are the students, the medical students, the undergraduates. So I worked with a very talented medical student by the name of Taylor Arnoff, who was kind of interested in cancer and dermatology. But anyways, during the research, we did some work looking into bladder cancer because Rhode Island has very high rates of bladder cancer, often 1, 2, or 3 in the country. It's a New England problem, but really highlighted here and not really understood. And I should say that one of my favorite genes is P21-WAF1, the universal cell cycle inhibitor I discovered more than 30 years ago. And early on, when this gene was discovered, many groups jumped on it to see if it's mutated in cancer. And the short answer about 30 years ago was no, it's mostly P53 mutations. However, eventually TCGA uncovered a unique mutational signature in bladder cancer in about 8 to 10% of bladder cancers. And it's kind of an unusual mutation with frame shifts and truncations that may have therapeutic implications that we have been interested in. But in this work, we found co-mutation with RB that were also these frame shift truncating mutations in a subset of patients that we refer to as the RW positive phenotype. And this is interesting to me because Betsy Plimak at Fox Chase and colleagues around the country had identified a signature with neoadjuvant therapy in bladder cancer that involved the genes ATM-RB or FANC-C. And it took me years to really understand that it's not the triplet, it's any of these genes associate with excellent responses to neoadjuvant therapy that could in the future help patients keep their bladders, which is pretty important. So we have continued to be interested in this subgroup. And I should say, one of the interesting things, if you read the paper, and we haven't really done anything with it, but I'm sure it's important, 100% of chromophobe renal cell cancers have this signature P21 and RB frame shift mutations. That's probably going to be important in that tumor type. So here in Rhode Island, we continue to be very interested in bladder cancer mechanisms. For as much as we know, I've sort of convinced myself that this signature in bladder cancer is not strictly a smoking-related phenomenon because we don't see it in small cell or other smoking-associated cancer. So something maybe concentrates a metabolite in the GU system and contributes to this type of mutation. It does not seem to be an ApoBet signature in and of itself. And so, we are continuing to work on this, but this did lead to a collaboration with Caris looking at this subset of patients with bladder cancer. And interestingly, the subset of patients with bladder cancer was found to have alterations enriched for FANC-C, CHEK1, WEE1, PALB2, BRCA1, and BRCA2 that were enriched, suggesting, certain inhibitors beyond cisplatin for these patients. And this one is not yet published either, mostly because we're waiting for a bigger data set with clinical outcomes. And, Infortumab gets in the way right now. But I do think that for a subset of patients with bladder cancer, this is promising in the world of precision oncology. So I'm going to give you another example. So our work on MDM2 and MDM4 got us interested, or we started noticing, hey, it took us to chromosome 1q32, where MDM4 is amplified in about 8 to 10% of glioblastoma. And it's a driver. There is no FDA-approved drug for MDM4, but there are relationships with patient outcomes. But I think what's coming out of this work, which I find very interesting and would like to pursue, is that the amplicon contains a kinase and a phosphatase, which may be more tractable in the near term as far as therapeutics. So there's the kinases PIK3C2B, not PIK3CA, PIK3C2B, and a phosphatase known as PPP1R15B. So, you know, the direction we're going with this is to look for kinase and phosphatase inhibitors that may be able to get into the clinic earlier than new therapeutics targeting MDM4, to which I think there really is a need in the field. And this is a good example, if those things cross the blood-brain barrier, as a precision oncology approach to a subset of patients with glioblastoma. I will report to you that the paper is written and it's been circulated to the co-authors. You know, some of them are in the room who got this before this meeting. So we hope to get it out soon. And I think there's a lot of work to be done on those co-amplified genes, including, you know, preclinical work to look at the cooperation of these genes and their individual or combined targeting as a therapeutic approach. So AI is a very exciting technology, but, you know, many people for some time now have been asking about clinical utility. And this thing over there just showed up in Nature Medicine. Show us the evidence for the value of medical AI. I think today we will hear from David Spetzler and James Hemrick and others about how AI is shaping the future of precision oncology. There are exciting directions with AI in predicting therapeutic efficacy in digital pathology and imaging, but I don't think anybody in this room is ready for AI to decide on our treatments or other issues in oncologic care just yet. But with regard to AI, and I should say, there is a collaboration between the WINS Consortium and Caris that has been developing for a couple of years, and it builds on some advances at Caris in digital pathology with the ability to enrich for suspected driver mutations from histologic sections. And so the concept I refer to as AIEE, for artificial intelligence for enrichment and equity. The equity part has to do with finding signatures that relate to drivers and maybe not having to test as many patients, so you save money, and then you can direct patients to appropriate treatments. And as this concept proceeds, there are a number of different drivers or different algorithms for each of the drivers. And, you know, this is the kind of approach that lends itself to global testing. And there are, you know, still a number of open questions that are being discussed about specific issues, but we have started to communicate with specific companies that have therapeutics to get their buy-in to be able to launch specific cohorts. That's where this is going. Now, here at Brown University, we have had a Caris registry protocol since the POA came here in 2019. And I would say that this registry protocol has enabled Brown faculty to collaborate with Caris through the POA membership at Brown. I will say I presented this slide a couple of years ago as an update related to the Caris POA membership. And at that time, you can see how many cases at Rhode Island Hospital and Miriam Hospital 3-4 years ago, or 2-3 years ago, how many investigators, how many projects, poster presentations, publications, and the access to a certain number of patients with all of the features that the Caris database offers as a wonderful resource for research. This is an update for 2026, and you could see the number of cases, the ones at Rhode Island Hospital and Miriam Hospital, and there are cases from other affiliated hospitals as well. And the number of publications since 2024 continues to rise. I will say that this is a great resource for us here in Rhode Island to look into things like, why do we have such high rates of bladder cancer? Because carcinogens leave fingerprints, and we can compare the signatures in genes like P53 or you name it from our region, where it's kind of complex with geography and toxic waste and all kinds of factors that can contribute to cancer. You know, this is near and dear with a precision oncology approval based on our research. The first ever approval for H3K27M mutated brain tumors on August 6th of 2025 after almost 20 years of discovery and development. And but this is where this is going from our own institution in the world of brain tumors and concepts for what's next, what's appealing to patients, what can we do? And so, you know, this concept has been emerging in recent months about treatment for these H3K27 mutated tumors in combination with other agents that have synergy and involving specific expertise on our campus. For example, Clark Chen with laser thermal ablation, or Eric Wong with use of tumor treating fields. And then at Progression, precision oncology approaches that are very popular with patients who want to know what all their options are. So I will end with some challenges in precision oncology. You know, some of this comes from work through the WING Consortium and their data committee. Jeremy Werner here is part of that committee. But some of what's been coming out, you know, are issues with privacy, data aggregation, ownership, complexity, heterogeneity, efficacy documentation, the need to be longitudinal in the data, among many others. But there are also opportunities and low-hanging fruit, and there's a paper that will be published soon, hopefully, that captures not just the challenges, but the opportunities. I will say the major challenges around the world, including in the United States, are access to testing, as well as access to and the cost of drugs. And, you know, we need to find ways of overcoming this, including regulatory changes and interaction with payers, so that the testing is covered and some amount of coverage is provided for at least a limited amount of time for patients to try. And this is particularly complicated when you're combining targeted agents in the manner that precision oncology is moving. But this is what patients want, and this is what any of us would want, and this is really the future in oncology. So I'll just say that the collaboration with Caris over the years has been tremendous for our institution. That's David Halbert, the founder of Caris, who had a vision. And, I've always enjoyed the opportunity of updating him about what happens here and what's exciting. And many other colleagues who are shown here, some of whom are in the room, and others, including Brian Brille, Narendra Chokshi, and Kennedy Cliff, who I don't see very much anymore, but still a good friend. And over on the right was a very nice image from the last WIND symposium with Nobel laureate Bill Kalin, and Jeff Elton was part of this, CEO of Concert AI, that also has a great collaboration with Caris Life Sciences. So we have a great program ahead of us, and I would like to thank Chiyoko and Sasha once again for the amazing efforts that pulled this program together. Thank you very much, and I will turn it over to David Spetzler and James Hambrick, who I think will introduce themselves as they proceed with their talks. Thank you.